We're going to discuss spontaneous bacterial peritonitis in this video, also abbreviated SBP. And SBP basically, by definition, is an infection of the acidic fluid that can build up. Now, what do I mean by acidic fluid? What is that? Well, I guess most of you, of course, know what ascites is. It's increased or accumulation of fluid in the abdomen, and in particular that peritoneal cavity, which is the space in between the organs and the abdominal wall. And ascites can happen in alcoholics, and it can happen in a lot of tropical infections as well. Hepatitis is another cause and things like that. But when this acidic fluid becomes infected, that's when you develop this SBP, spontaneous bacterial peritonitis. It's a very basic definition. Now, organisms that are responsible for infecting that acidic fluid include E. coli, and it's also Klebsiella. Klebsiella can also cause an infection, and Strep pneumo, interestingly, is also one of the causative organisms. And these organisms are usually singular. It's usually a singular organism that's the infected, that infects the acidic fluid. It's usually not multiple. Okay, so then let's talk a little bit about the symptoms. The symptoms of SBP basically involve a lot of the same symptoms that you'd have with ascites. You remember ascites is a big swollen belly, almost looks like the person's pregnant. But with infection, you can also get some additional symptoms. So some of the symptoms of ascites include, of course, abdominal distension. You can also have abdominal pain, pain or tenderness, whichever way you want to describe it. Another thing is dullness to percussion. This is a very important physical exam finding. When you ask the person to turn to the side and you tap the abdomen, it's very hard because of that fluid accumulation. Now, when you get SBP, which is of course an infection of that acidic fluid, you can also develop fever, you can develop malaise, and the person's hepatic failure can worsen as a result. So those are some of the basic signs. It's pretty obvious. I mean, ascites is obviously pretty obvious, but if a person with ascites comes to the ER or hospital with fever and malaise and worsening abdominal pain, then it's a pretty diagnostic symptoms and signs. Well, how do you diagnose it for sure? Well, you do something called an abdominal paracentesis, and these are done quite often because these types of patients actually, there's such a strong recurrence that they have to keep coming back to get this paracentesis. And a paracentesis, essentially, you're draining the acidic fluid. You insert a small needle and you drain that fluid. And once the fluid is drained, you analyze it. You analyze the acidic fluid. You do a culture. You can do a gram stain, and you can discover a lot of things with these tests. You can discover the etiology, and you can discover the content of the what's inside the acidic fluid, and that can help you determine what's going on. And like I said, 70% of the time, people with ascites will most likely recur. So the recurrence rate is very high. So the abdominal paracentesis kind of acts like a band-aid. It's not really a cure. they develop this ascites, SBP. They come, they get the fluid drain, and then sometime later they have to come back. So it's kind of a back and forth. The treatment of this, obviously, well, the treatment involves, the paracentesis. I mean, I guess the paracentesis can be kind of thought of as a diagnostic tool and a treatment. But the real treatment of SBP, spontaneous bacterial peritonitis, when there's an infection, is of course antibiotics. And the treatment of an acute SBP is usually a cephalosporin like cefotaxime. And because SBP can recur, you also want to give prophylactic antibiotics. So remember, this is for the treatment, but prophylactic antibiotics are given to prevent or at least reduce recurrence. And quinolones, fluoroquinolones, are used. And remember, the one that I've always seen on licensing exam is levofloxacin. So remember that. That's the one for prophylaxis. I've got a couple clinical vignettes I'd like to go through, and here we go. 56-year-old man is admitted to the hospital for fever and abdominal pain. He has a history of cirrhosis and is known to be hepatitis C positive. He was diagnosed with cirrhosis 4 years ago. His only medications are spironolactone and propranolol. He reports that 5 days ago he had a fever up to 102 and gradual onset of diffuse abdominal pain. On exam, he has a fever, 101. His blood pressure is 100/50, pulse is 110 and regular. Lungs are clear. He has numerous spider angiomata on his thorax and back. Abdomen is massively distended. Shifting dullness by percussion. Lab studies show leukocytes of 13,200, hematocrit 33, prothrombin time of 15, albumin was 0.1, sodium 135, potassium 4.7. Which of the following is the most appropriate next step in diagnosis? Well, you've got a lot of great clues in this vignette. You've got fever, you've got abdominal pain, abdominal distension, and then you've got that great shifting dullness. That's a great physical exam finding. You ask the person to turn to their side, and then you tap on their abdomen, and it'll be very, very hard. Well, this most likely, and combined with the fact that he has liver disease, most likely means he has a person with ascites that now has become infected, and as a result he's developed SBP. And they're asking, how do you diagnose it? Well, if you remember, the main thing to do initially with the diagnosis is you do an abdominal paracentesis, and then you take the acidic fluid and you send it for analysis, culture and gram stain. So the answer is D. And then finally, a 62-year-old woman is admitted to the hospital with severe ascites and fever. She has a 2-year history of portal hypertension secondary to hepatitis C-induced cirrhosis. 4 months prior to admission, she suffered an upper GI bleed secondary to esophageal varices, which was subsequently banded via endoscopy. 2 days ago, the patient developed abdominal pain, increasing abdominal girth, and fever. She was admitted to the hospital with the diagnosis of spontaneous bacterial peritonitis, SBP. The appropriate therapy is initiated, and over the course of the next 4 days, the patient appeared to be responding well. On the day of discharge, you begin to plan her outpatient management and follow-up care. To prevent further disability from her current acute condition, you should prescribe. Another very good question. They've given you a lot of clues. So what's happened here is this is obviously a patient with liver disease, and she's most likely an alcoholic. How do I know this? Well, I don't know this for a fact, but I'm assuming because she had esophageal varices that she's most likely an alcoholic. And as a result, she's now got ascites, which is pretty obvious. I mean, that kind of tells you right there. And then the fact that she's come to the hospital with fever and well, it even tells you she has ascites. So the fact that she's come to the hospital with fever means that she's developed SBP, and the question even tells you that. Now, interestingly, in the latter part of the question, they said that the appropriate therapy is initiated. So what I'm thinking is that they're giving her cephalosporins, because if you remember, the treatment is a cephalosporin, most commonly if I can spell it, cefotaxime. Now what are they asking? They're asking to prevent further disability from her acute condition you should prescribe. What they're really asking for now is, what do you do for prophylaxis? And if you remember, the prophylaxis of SBP involves fluoroquinolones, and most commonly that fluoroquinolone is levofloxacin, which would be C. Fluoroquinolone, FQ for short.